clinical case report. Incidentaloma, a mandibular fracture case report. Incidental findings Incident findings are previously undiagnosed medical or psychiatric conditions that are discovered unintentionally and during medical or psychiatric conditions. Incidentaloma is radiological knowledge for incidental findings unrelated to the original diagnostic inquiry, which helps in early diagnosis of suspicious lesions. The cardiac incidental findings percentage rate is 67.6%. The percentage rate for renal incidental finding is 60%. The percentage rate for intracranial incidental finding is 27.1%. Most of the systemic defects or pathology are identified as incidental findings. Here I am showing a few examples of incidental findings. First one is the pericardial cyst, which is found in the CT of heart. Second is the renal cell carcinoma, which is found in the kidney. And the third, the patient came with a complaint of a simple headache. Later in the CT of brain, they diagnosed as an intracranial lymphoma. Now we are going to see maxillofacial incidental findings. Like medical findings, in dental also, so many incidental findings are there. Few examples of the incidental findings are impacted canines, orontomes, dentigerous cyst, central hemangiomas, and intraalveolar carcinoma. These incidental findings are identified when we took radiographic findings for routine investigations, orthodontic treatment, or any fracture or prosthetic or implant treatment. Here I am providing one such article which shows an incidental discovery of ontogenic keratocyst in an aneurysmal patient. This is an occlusal view showing the well-defined radiolucency. Coming to our case report, a 50-year-old male patient reported to OMFS department with the chief complaint of pain in relation to mandible following a road traffic accident, skid and fall from two-wheeler and had sustained injury to face. On examination, in local examination, patient face was apparently symmetrical, presence of tenderness in relation to left parasymphysis region and right condyle and angle region of mandible. Mouth opening was recorded at 40 mm, which is normal. Mobility of teeth was evident in relation to lower right third molar. No segmental mobility was detected because of the ceramic bridge in relation to the lower anteriors and the extraoral suture lacerations in the chin region. With the we have come to a provisional diagnosis of parasymphysis fracture and right condyle fracture. The investigation for this case is CT scan, X-ray orthopantomogram and incision biopsy. The preoperative 3D CT reveals an undisplaced pathological fracture of the right condyle and an undisplaced fracture of the left parasymphysis of mandible. An OPG revealed a presence of radiolucent lesion of a size 6 cm by 2 cm by 2 cm in relation to right posterior mandible extending from the distal aspect of lower right second molar to the neck of the right condyle, and then a radiolucent lesion of an left parasymphysis region. With the radiological finding, we are suggestive of ontogenic keratocyst, but we are not concluding this as a final diagnosis. With the biopsy report only, we can confirm it. So the histopathology report suggests the margins are free from tumor and it reveals the areas of necrosis with focal areas of ontogenic epithelial outlines, with features of malignancy, with areas of keratin pearl formation and inducted dentinoid formation, and peripheral satisfied squamous epithelium was seen. And we are coming to a final diagnosis with the biopsy report as an ameloblastenic carcinoma of mandible. Treatment done for this patient was right hemimandibulectomy, and the flap was taken from the pectoralis major myocutaneous. This is the resected specimen of the right hemimandible, and the post section, incision marking for the flap. This is the pectoralis major myocutaneous flap harvested. Discussion. According to WHO definition, ameloblastenic carcinoma is defined as a rare primary ontogenic malignancy that mixes the histological features of ameloblastoma with cytological atypia. have malignant odontogenic epithelial neoplasm that arises de novo or from a pre-existing odontogenic lesions. McIntosh reported that amyloblastic metastasis was first reported in the lung, which was thought to be aspirated from oral lesion due to curettage and enucleation surgeries, which might liberate neoplastic cells into upper airway spreading to lower airway. It may undergo malignant transformations spontaneously following a radiation or following a chemotherapy. It has two variants, granular cell type and the clear cell type. In our case, we did a sanitile node biopsy and it had been negative, and further dissection wasn't done. There is still controversy regarding the neck dissection for amyloblastic carcinoma in clinically and radiologically negative neck. The treatment of choice for amyloblastic carcinoma is the surgical resection. In order to confirm a disease-free survival, an en bloc resection with 1 to 2 cm of normal bone margin, the safest surgical modality, which has shown a local recurrence rate of about 50%. So most of the amyloblastic carcinomas are intraosseous. Therefore, the effectiveness of radiation must be considered critically. The survival rate is majorly determined by regional or distant metastasis and local recurrence. According to this study, 5 years of survival rate after surgery and radiotherapy without recurrence or metastasis is accepted. Futuristic aspect: identifying the dental incidence at the earliest stage will reduce the morbidity and mortality of certain conditions, which will certainly increase the patient's longevity. To identify at this earliest stage, a radiological finding, that is orthopantomogram (OPG), can be included in the regular master checkup so that the hidden malignancy can be identified and treated in an earlier stage. Conclusion: this case report gives an insight about amyloblastic carcinoma, which has its very limited evidence in the literature, and emphasizes on the importance of routine radiological examination, which has to be included in the regular dental checkup to diagnose such pathologies in earlier stages. Amyloblastic carcinoma cases must be studied carefully histologically in order to differentiate it from ameloblastoma and malignant ameloblastoma with proper assessment of nodal metastasis. So that the OPG has been included in part of a routine investigation, we can easily able to identify such dental incidental findings and can be treated at its earlier stage. These are my references.